I shared with you the problem of dementia that have touched my family. Now I'm going to tell you the solution, and I'll focus on the minimally viable solution. This is a terminology we use in Agile Science. It primarily is the active ingredients um, of a solution, that all the active ingredients have to be um, delivered to guarantee an effect of a solution. And the minimally viable solution for us is called collaborative dementia care model. It has five essential elements. The first one, the solution is it has a public health perspective or population-based care, and it's accountable for every member of that population that's specified. Okay. Then the second essential element is the solution focus on what we call measurement-based treatment to target. It has a specific target, and it measure that target, and it try to reach that target in using stepped care-based process. It is not just patient-centered, but it's family-centered or caregiver-centered. It delivers specific evidence-based care. And obviously, the accountability come over from making sure that there's certain targets, in this case, the ability of the caregiver to cope with the cognitive, functional, behavioral, and psychological symptom related to their loved one living with dementia and their own stress. And we want to make sure they are not stressed out, or they are if they came in stressed out, they will be in remission within 12 months, almost 90% of them. And that remission defined by a specific target number of 15 on the healthy aging brain care model that I'll explain to you a little bit. We held ourselves accountable to 100% adherence of our caregiver to the stress prevention bundle. We held ourselves accountable for less than 5% of our population have a 90 days readmission from any hospital visit. And we try to increase the number of our patients living in the community. Cumulatively, we want to keep it 24 hours, 24 months longer in the community. Now, let me come back and focus on one specific evidence-based care model. Our solution have what we call the caregiver stress prevention bundle. It has four elements. Number one, we work hard with the caregiver to make sure they take 8 hours time off caregiving task in one block once per week. Number two, we work with them on assuring they attend at least once a month of a support group. Number three, work with them on developing crisis plan. People with dementia, they and their family face a specific and relatively predictable crisis. We just don't know the timing. So we work with them on developing crisis plan ahead of the time. For example, if this happened, then you do this. Example of these crises is driving cessation, protection from financial abuse and scams, dealing with urgent visit to the emergency room or not, dealing with agitation, trying to have a plan if there is a need to use formal or paid caregiver to support patients' ability to maintain their independence, or assisting them in meeting their basic activity daily living in the home, or if that's require moving outside the home. And finally, work with them and coach them on how to cope with the cognitive, behavioral, functional, psychological disability related to their loved one with living with dementia and their own stress. And we also have a specific program on how to manage their medication, including reconcile the medicine, make sure they are taking appropriate medicine, and deprescribe inappropriate medication. And then we have a specific transitional care from home to the hospital, from home to the emergency room or back, or sometime from home to subacute rehab through the hospital or not, and have a specific transitional care protocol for that. That's the evidence-based care. Then this concept of measurement-based treatment to target, and here we use the Healthy Aging Brain Care Monitor. We have a caregiver version and self-report version, and we use their number that I will go over later on as a target for us to know if the patient need more coaching for us or not, if the patient's care plan and the diet care plan need modification or not. So that's in a nutshell the collaborative dementia care model, the minimally viable or active ingredient in the collaborative dementia care model. Now I'm going to tell you the 2 years history. How did we face the problem of dementia? I gave you the solution, but how did we develop, implement, scaled, and sustain the solution? In this two-decade journey, you'll notice our focus on this implementability, scalability, and sustainability, and that put constraint and on the way on the tools and process and strategy we have to use to to solve the dementia problem. This whole story started in the early 90s in Indiana University when I wasn't even there yet. I was finishing my residency program and doing my fellowship between Cleveland, Case Western in Cleveland and University of North Carolina in Chapel Hill. Prior to come up with the collaborative dementia care model, my mentor, Chris Callahan, has worked and developed the collaborative care model for depression, and it's called Impact. And he took a lot of active ingredient from that model and modified it, localized it as an attempt to meet the complex biopsychosocial need of patient living with dementia and their caregiver. So he designed the beta version of the aging brain care model or the collaborative dementia care model. In 2001 and 2006, we executed a randomized controlled trial that evaluated the collaborative care model or the aging brain care model. Our primary outcome at that place was behavioral and psychological symptom related dementia as measured by the neuropsychiatric inventory, caregiver stress, and providers, primary care provider satisfaction. These were our main outcome measure. We tracked the cognitive function of patients and their functional status, their ADL, IADL. So between 2001 and 2006, we executed a clinical trial, and the clinical trial was positive by actually meeting its primary outcome measure. And then between 2006 and 2012, we put all our efforts on actually implementing the model that was positive based on clinical trial. We published it in JAMA. We tried to convert it into a clinical program. It took us a year and a half to convert the JAMA article into a clinical program that was open in 2008 to serve people in Ashkenazi Health, the safety net healthcare system. We published the JAMA article in May 2006, and the program was opened as a clinical program in January 2008. During that process, we developed a local collaboratory in Indianapolis that include all memory care practices in Indianapolis. And they were our advisory board. They co-designed the program with us. They give us a lot of insight on the translating the JAMA article to an actual clinical program. And we did that under what we call Indianapolis Discovery Network for Dementia. And that network helped us translate the JAMA article into local program. In the same time, we got connected with other investigator and scientists and clinician from UCLA, primarily David Rubin, Hopkins, and Greifswald in Germany. We developed and validated the Healthy Aging Brain Care Monitor as our measurement-based treatment to target tool that was multi functionality, practical, take less than 5 minutes to complete. We had to do that because the tool we used in the clinical trial was not practical. It took more than 45 an hour to complete, and it was multiple tools. So we had to consolidate them into this Healthy Aging Brain Care Monitor. We had to develop it and validate it. Then we also developed software called EMR ABC to allow us to hold ourselves accountable to meeting the biopsychosocial need of the patient and allow us to revise the care plan accordingly. And in the first 6 years, we were able to serve around 1,000 patients in Indianapolis. So it wasn't big time scalability, but at least we moved it from the JAMA article to an actual clinical program.